Just to pass good evening, good morning in other parts of the world, and good day. We just want to acknowledge and appreciate each one of us that has been able to join in this call. We appreciate it. It's a wonderful sacrifice and commitment indeed to come on and just put aside everything that I would have loved to do at this time of the day with our family members. But indeed, it is a great investment for our community in Lesotho, for us all to exchange the knowledge. As we know, Project ECHO, it is the model that we all acknowledge each one of us has got something to offer for the table. So it's all teach, all learn. We all have something to share and empower one another. Therefore, tonight's session, we are really, really grateful. We have got Dr. Gillian Chowns and Dr. George Smerdon, who will be sharing their work and experience with us in terms of effective communication in palliative care from the cultural sensitive aspects and also grief aware approach. We want to also acknowledge and thank everyone that has been able to join in last week. We had a challenging connections with most of our colleagues, but we hope you are able to catch up on the recording, whereby last week it was about the introduction and also stating how palliative care initiatives have been attempted in the past in Lesotho, and we are in this new journey to see how best we can make things progress a little bit further than the last times. So tonight it is about Dr. Gillian and Dr. George making their presentation. Following that, it will be all of us in a large group discussion. After that, it will be the case presentation by myself, and then we will be taken into breakout rooms whereby we'll have the faculty members facilitating the discussions, whereby we will be all dissecting and exchanging the information on the basis of what we have learned and the strategies for breaking bad news. Then after that, we'll come back to the main room, whereby we will all now have a bit of discussion. Probably if we have chance from each and every group, we could have a representative that will feed back to the group to share what we have been discussing in our individual small groups. And then it will be announcement and the closure. That is it. So on this juncture, I would like to really humbly pass on the responsibility and this moment to both Dr. George and Dr. Gillian to really get on with the presentation. Thank you very much. They will start by introducing themselves, please. Thank you.
Thank you, and thank you, Tebello. We're really pleased to be here. I wasn't able to be here last week, but because I was away in France. But let me introduce myself. I'm Dr. Gillian Chowns. I'm a social worker by profession, and after many years in social services in the UK, I moved into palliative care, working mainly with children and families. My research area was focused on the experience of children who were in themselves well, but whose parents were seriously ill or dying. I'm one of the trustees of Palliative Care Works, PCW, and I've taught in Kenya, Tanzania, Ethiopia, Ghana, and I've traveled elsewhere in Africa. And I'm looking forward very much to actually teaching face-to-face in Lesotho in due course, probably 2024.
Hello, everyone. I'm George Smerdon, a retired family doctor in the UK. And it was really good to meet some of you last week. Throughout my career, I've been passionate about palliative care. And in retirement, I've been fortunate enough to be with Palliative Care Works as a trustee. And like Gillian, have taught in several places, Tanzania, Zambia, Ethiopia, and again, like Gillian, hoping to be in Lesotho with you all at some point in the future. It's a great pleasure and a real privilege for us to be part of the faculty, working with Erin and Mayor Tebello and with you all together. I'm excited about the ECHO programme, and I'm looking forward to sharing experiences, all teaching, all learning from each other. So today we're going to be looking at communication skills in palliative care, as well as helping you to explore some of the culturally sensitive issues around death and dying. We know many of you are already very experienced, communicating very effectively with your patients and their families and your colleagues in your everyday jobs. But in palliative care, you will be aware that particular skills are needed to support patients and their families, to help with difficult decision-making, as well as sharing bad and distressing news. And we have to come to terms with not being able to save the lives of our patients, and this needs to be confronted. This is either because treatments fail or because people come seeking help at a late stage in their illness, or indeed both. And central to this is the need for cross-cultural awareness, and with it, cultural adaptations around communications. And we'll be talking more about this later. And of course, looking to hear from you all about your own experiences. All of this places a great strain on everyone. You understand how difficult these topics can be. Our patients, their families, and their carers, and us, their professional support. And we must always remember our own personal experiences play into this. So this professional communication is a skill, and like any skill, can be taught, but must also be practiced. And you will understand that in real life, we often struggle to get it right. So today we're going to start with a short presentation on communication skills, and for some of you, this may well be a revision. We'll also be looking at breaking bad news, as Tebello has said, something we all find challenging. So we're hoping today's session will generate lots of talking points, especially around areas you find challenging in communicating with patients who are living with and dying from life-limiting illness. We really want this to be as interactive as possible. And we're very grateful to Tebello for facilitating the discussions and to other faculty members for supporting the discussion groups. So over to you, Gillian.
Thanks, George. So you will see from the slide that's already up that there are 4 key learning objectives for this session. We hope that by the end of today, you will understand and be able to apply the principles of good communication. As we've mentioned before, it's important to exercise cultural sensitivity and something we call humble curiosity in all interactions, being interested and wanting to know and understand what it is for the patient and their family. It's essential to recognise grief as a unique component of the patient and family's journey. And this grief happens not just after death, but also beforehand. And we're going to offer you a couple of models about breaking bad news, spikes, and the break news model. And we'll be looking at that a little later on. So that's the aim for our session today. Now, in terms of effective communication, it's really important to realise that it's always two-way. Next slide, please. It's a process of exchanging ideas, thoughts, opinions, knowledge, and data. But the key thing is to ensure that the message is received and understood with clarity and purpose. When we communicate effectively, both the sender and receiver achieve a better outcome. But actually, if we can communicate, or we think we do, but if it's not received and understood, then actually communication hasn't happened. We've had a rather interesting example of this in this last week, when between George, myself, and Tebello, we've been discussing this evening's plans and realised, fortunately in time, that we all 3 had somewhat different understandings of how to proceed. So that checking out is really essential to make sure that what we think we have said has been heard and understood by the receiver. That's absolutely key. So just a reminder of what good communication achieves. Next slide, please. I think there are 4 essential things, first of all. Good communication creates relationships, and it's relationships that really make work effective and really make the process in health and social care work well. Good communication enables expression of feelings. And while we're always concerned about the facts of a case, actually the saying feelings are facts is equally true. How people feel really makes the difference. When we have a good communication, when we have a good relationship, it gives value to the other person. They know they are appreciated and cared for. And if we do those three things, then isolation is reduced. When you have a difficult diagnosis and prognosis, you feel really isolated. So anything we do to reduce that is good. Given those four things, we can then move on into facts. Good communication gathers information. We gather information from the patient and from the family. And that enables us to give information back that's relevant and appropriate. And all of that reduces uncertainty. And it's uncertainty that's such an overwhelming and frightening feeling for so many people who find themselves seriously ill. So it's really important to remember those points. I'm going to hand over to George now, who's going to talk to you about empathy and humble curiosity.
Could I have the next slide, please, Stephen? Thank you. Yes, let's look at in a little more detail at some of these components. Empathy is the ability to understand and share the feelings of another. If you have a look at the 5 points around empathy and see if you recognize those that you personally feel comfortable and confident about and others that you may need to work on. For instance, you may feel you're a good listener, but can you show that you really understand what your patient is going through, what their family and carers are going through? How about giving appropriate support when needed? And self-awareness is so important in communication. Always, can I do better? And this lovely concept of humble curiosity. What is it that I can learn from you? And how can I learn from you? You'll understand that this includes acknowledging and respecting the cultural differences that are around us all in different societies. Traditions and belief systems, particularly around death, dying, grieving, and bereavement. And I really hope that we can discuss this more, not only in the big group, but more particularly in the small group. So can I have the next slide, please, Stephen? Another important component of effective communication is around diversity. So this slide expands on the theme of awareness and communicating, not only with our patients and their families, but also with each other as health and social care providers. It's important to try and understand how culture and diversity impact on health and social care, particularly in palliative care, how age, gender, class, sexuality, our patients' level of education, their religious beliefs, and indeed all of these aspects of diversity can affect the way our patients feel who have suffering from life-limiting illness. Acknowledging and celebrating cultural differences and diversity can be difficult in some societies. And how we encourage our patients to share their life experiences, including their beliefs, concerns, and vulnerability, is an important skill, especially in palliative care. Next slide, please, Stephen. This is to remind you how little we need to say and how much we need to use non-verbal skills when we're communicating with patients, especially so in palliative care, where emotions are often running so high. What we do say, therefore, needs to be clear, and as Gillian has said already, in language our patients and their families understand. The non-verbal components are well known to you, I'm sure. The skill is how best to use them and adapt them for the benefit of the individual. This is about active listening and, again, self-awareness. How you sit by your patient or crouch at the bedside, your facial expressions, the tone of your voice, nods and encouraging phrases, the use of silence. It's all about enabling and encouraging your patient to tell their story. There's that lovely phrase, know your patient. And we'll talk more about this shortly. You notice we've emphasized cultural appropriateness, being sensitive and check with your patient, particularly around touch, asking if it's okay to do this as you reach out to a distressed patient. A gentle hand on the arm or shoulder can be really comforting, but not if it's inappropriate. Next slide, please, for Gillian.
Thanks. Georgian's already mentioned the question of self-awareness. It's really important. We've talked a lot about it. It's about recognizing our own preferences, our own values, beliefs, and then to a certain extent, holding them to one side. We work with others who may think things through rather differently, who will see life differently. For example, it's quite possible that we may feel that we should always be grateful to God, no matter what happens. But I can think of a number of families I've worked with who've been angry with God or in complete despair. We don't have to change our own beliefs or values or deny them, but neither should we impose them on those that we are working with. And while Maya Angelou is absolutely right that it's about how we make people feel, people will remember what we said, they will remember what we did, and the way we do that has consequences. And if they're left feeling devastated or unvalued, then we've done them a great disservice. So, George, for you next.
Next slide, please, Stephen. Thank you. So some of this will be a recap, but try imagine being with the patient now. How will I use my skills, knowing that conversations with patients in palliative care will often be emotional, distressing, and challenging? We've seen how important active listening skills are for effective patient-centered care. If you listen well, your patient will almost always tell you all you need to know. And note, sorry, Stephen, can we have the whole slide up there? Thank you. And note the 80-20 rule. Paying attention and not interrupting shows your patient that you care. This is on the left-hand side of this slide. That you value what they're telling you, it builds trust. Silence is an active skill and gives time for the patient to think about what to say next and also to experience their feelings. Never be judgmental. Allowing a person to voice their concerns and fears can bring great relief and help them to feel less isolated. The patient will often pause before they share something important or painful. And if you break that silence, it can disrupt the whole consultation. As an extension of good listening skills, you need to develop the ability to reflect words and feelings back to the patient and to clarify you have understood them correctly. An example could be, you seem quite angry, or what I'm hearing you say is that you don't feel your children are being very supportive. Is that correct? Using open questions encourages the patient to share their thoughts and feelings and adds clarity if you're not sure about something. And throughout the conversation, check where you are, summarize, as and when you feel it's important, as and when you feel it's helpful by sharing thoughts, so that when you come to next steps, this enables planning and decision making. Gillian.
Right, now let's move on and consider one of the major issues in effective communication, breaking bad news. Breaking bad news is anything that changes a person's view of themselves or their future. We may immediately think of a cancer diagnosis or prognosis as the worst of bad news, maybe. But equally, when a patient is told that it's time to give up running his street stall, or told that they need to let their adult son manage the cattle herd, things like that, also constitutes bad news for them. And the consequence of that breaking bad news is that they will inevitably grieve. So grief is a terrible sense of loss. George, you want to contribute here?
Yes, could I have the next slide, please? Grief, that terrible sense of loss, as Gillian says, it is natural and normal and unique to the individual. We've all experienced it and will many times in our lives. The distress of losing a loved one is devastating, and you will have seen grief triggering a range of powerful responses, physical, emotional, and spiritual, and these will often come out over a period of time. We talk about attachment. The more attached a person is, the greater the love, the greater the sense of loss, the stronger the grief. Attachments are both tangible, things that we can see and touch, like a person, a house, a car, a place, and intangible, for example, ideas, dreams, goals, expectations. I'm not sure if you're familiar with the term anticipatory grief. It's that sense of loss before an actual loss. It's often not acknowledged, talked about, or even understood. There may be something to talk about in our groups, as it has real relevance to breaking bad news. Of course, grief isn't only death-related. We grieve for the loss of health, of a friendship that has ended, or losing our job or an ambition. If people have had to leave their homes, there may also be grief for their past life, their culture, and families left behind. And not forgetting the need to acknowledge the various rituals and customs that are often so helpful to those grieving. Gillian.
So, breaking bad news really matters, and how we do it is absolutely, essentially a skill that we need. We need, when we're talking about, when we're breaking bad news, to really bear in mind how we do this. And I've lost count of the number of families who can recall word for word what the nurse or the doctor said, who recall where the bad news was delivered and how badly it was done. It's burned on their memories. So Buckman is absolutely right. If we do it badly, the patients or family members may never forgive us. If we do it well, they may never forget us.
Next slide, please. So breaking bad news is about being honest. It's about telling the truth. So why is it good to tell the truth? People will certainly cope better with the truth than with uncertainty. We all know this in our everyday lives. Even if the truth is painful, and lying will always destroy trust. It helps with decisions about treatment and care. And you will know that sometimes with the distress of living with life-limiting illness, patients and their families spend much time and money searching for treatments because no one is brave enough to tell them that there is no cure for their illness. And preparing for the future might involve writing a will, planning a funeral, doing something they had always wanted to do before they died, seeing somebody they'd always wanted to see, something which they may not have done if they did not hear the truth. And also, really importantly, it gives an opportunity to put things right if there's some what we call unfinished business in someone's life. And for many, many people, the importance of exploring spiritual issues. Again, it would be good to hear your thoughts on this, especially from your cultural perspective. Next slide, please, Stephen. So we come to breaking bad news. I'm sorry if we're going quickly through this, but we can explore more leisurely some of these themes in the group work. Breaking bad news is always difficult, but we can all learn to do it sensitively and compassionately, gently but realistically, and with honesty. It can make a devastating and distressing situation so much easier to cope with for patients and their families, as well as for ourselves as professionals. It needs practice, and again, we don't always do it as well as we would hope. And we all know what happens when it goes badly. So here's one model to look at, known as spikes. And this was initially offered as a protocol for delivering bad news to cancer patients, since which it's been adopted more widely and is a useful framework for communicating difficult news to patients in a clear, supportive, and we believe compassionate way. I know how important this is to you, so having the recording and the slides will help you to go over all this again in your own time and with colleagues. So if we take the acronym SPIKES, S is for the setting, the setup, getting prepared. You might say, let's find somewhere quiet to talk. So think about what you want to say well in advance. You should have read the notes and have all the information you need about the patient. Try and find a time and somewhere quiet where you won't be interrupted. I know that's easier said than done if you're in a busy clinic or on the ward. And ideally, of course, it would be in the comfort of a patient's own home. But you understand the principle. It's really important to check how you are feeling and try and leave behind your own pressures. So it may be helpful to have another colleague involved in the patient's care to be present with you. It's really helpful if the patient has a relative with them. We know there are sometimes cultural reasons why certain relatives might also need to be in attendance. You'll need to make the introductions, bearing in mind everyone is going to feel anxious. Again, active listening skills to the fore. Gillian.
Okay, so P is for perception. I'm not sure if somebody's not muted, needs to be muted. Can you just all make sure you're muted, please? Okay, so P is for perception, which really is about uncovering what other people perceive, what the patient and the family think is happening. Really, it's really important to always seek information from the patient and the family before you give information. So having some appropriate phrases ready can be really helpful. I often say something like, I've read all the notes very carefully, but I'd really like to hear from you. What have you already been told about your illness? What's your understanding of why you're sick? So you start where the patient is. You hand the baton to them, as it were. This way, we then get a better sense of where they're at, what they're thinking, and it helps us to work out what we're going to say and how to begin. So I think that that's really, really important. Then we're able to move on to the question I of invitation, that is asking them what they would like to know. So again, we're keeping the patient and the family in front of us as primary sources. Now, most patients want to know about their condition, but there are some who don't. They don't want to, and that's their particular coping mechanism. And you'll soon pick this up by their body language and what they say or they don't say. And we have to respect this. But it can be very frustrating for us, I think, especially when we're aware that there's very little time left. But if your patient doesn't want to hear the details at this particular time, you can always offer to answer any questions in the future or say that you're happy to speak to their family or their friend. We have to go at their pace, but we always have an opportunity to check next time, would they like to know more? The other thing I think when we're asking patients about and families about the situation is being very careful about the language that we use. We need to adapt it to the patient's level of understanding, and no jargon, no acronyms, no jargon. It just causes confusion and makes it more difficult for the patient to understand what's happening and to be clear about their situation. We erect a barrier of communication if we do that. And it's not just jargon, it's often particular phrases. We need to be careful, for example, of phrases like, we note that there's been some progression. We may know that we mean that the disease is already advancing, which is bad news. But the patient associates progression, progress, with things getting better. I can think of many consultants who've said to a patient, well, you're not fit for chemo yet, as if there will be a time when they'll be fit. And yet we know that's not the case. So be very careful about the language that we use. George.
So K is for knowledge. This is about explaining the illness and care options, as Gillian says, in plain language. So warning the patient that you have bad news may reduce the shock. So again, using phrases that signpost where the conversation is going can be really helpful to the patient. For example, I have the results of your latest blood test or recent X-ray or scan. I'm afraid it shows that there is a serious problem we need to talk about. Or it seems that the treatment you have been having is not working as well as we had hoped. we need to talk about it. So your patient and their friend or relative will need enough time to absorb the new knowledge and ask questions. They may very well be very emotional. There may be many questions, some of which you may not be able to answer either then or possibly even in the future. So be honest. Give the patient information about what can be done to try and help and when they will be seen next. Above all, reassure your patient of ongoing support. This will help them to cope and feel less isolated. Gillian.
And so we come to E for emotion. And that's absolutely critical, I think. Emotions are very, very powerful. Don't move on to think about tasks, options, or possible solutions until you've given the patient or their family the opportunity to share their feelings, to express their emotions. And be careful about your assumptions about what they're thinking and feeling. We might say, for example, I expect hearing this is very upsetting, only to find the patient says, well, actually, no, I was expecting to hear this. I know how sick I am. So be wary of assumptions. As we said before, active listening skills and remembering that all patients are different is really important. George.
So we come to the S of spikes, and this is for summarize. It's about a recap and understanding what's next. Everybody understanding what's next, not just your patient and their fans, but you and your colleagues. It's important for all present, therefore, to say something here by way of sharing their understanding, the patient always going first. How you summarize can confirm the patient's understanding, and it's also an opportunity to clarify any misunderstandings. Again, this is practicing reflections. Encourage them to express their concerns and suggest they and their relatives note down any questions they'd like to ask you at your next meeting, reassuring them that this is an ongoing conversation. It's important to remember that it may be necessary to pause the discussion and come back to it later. If people have become really upset or unsure, then it's important to recognize that and step away. Always check how your patient is feeling and responding. As we've said before, go at their pace. And finally, it's worth remembering that there aren't many absolute rules in palliative care, but one is never say, there is nothing more we can do. The mantra of palliative care is there is always something that can be done. You will know that it will not always go as smoothly as this or as you would want. So remember, it's good practice to share with a colleague after a difficult consultation like this, how it went for you and how it has left you feeling afterwards. So we do recommend that you go over spikes in your own time and share it and practice it with colleagues so as to feel a little more confident when faced with this. And you will have a skill set that you will be able to use on many occasions. And now Gillian is going to mention another model that we at PCW have developed. It appears in our PCW toolkit.
Thanks, George. And this one again uses capital letters to help you work your way through it. Break news. And you'll see that there are many similarities with spikes. So we start off again with being prepared, reading the notes, getting the scene right. We've talked about relatives and just how important they are. It's very valuable to have somebody else there, a relative or a friend, who may hear things differently, may remember things differently, and who at the end of the day is going to be supporting the patient and being alongside the patient for many more hours and days and weeks than we are ever going to be. This question of expectations or perception, as we talked about in spikes, getting a picture of what they expect, what the patient expects, what the patient thinks is happening. Because if we have that picture, that expectation, that understanding, then we can assess what is appropriate in moving forward in our conversation. We need to share the knowledge and to be open and honest about that. And then just as George was saying just now, never say there is nothing we can do. We may need to say clearly, I'm sorry, we cannot stop this disease advancing. We cannot cure you. but can help your family. We can relieve your pain. We can deal with your symptoms. That's a way of empathizing with the situation they find themselves in. Then we can move forward, talk about the way forward, the options that are available, what is likely to happen. Even when we do it very well, it's difficult. And so I think that last S, stop and reflect, is really important. It's hard work breaking bad news. It's emotionally exhausting for us very often. And when we are doing it time and time again, it takes a toll. We need to remember that we are not Superwoman or Superman. Don't demand too much of ourselves. Stop, reflect, share with colleagues, care for ourselves so that we can care for others. So take that time to stop. And now, just before we stop, we have time for some thoughts, some ideas, some questions, some reflections. It would be really great to hear from you. And please raise your hand and do introduce yourself and tell us where you're working and what your job is. And we look forward to hearing from you now.
Thank you very much, Dr. Gillian and Dr. George, for the wonderful presentation. And I do believe our colleagues will have definitely appreciated these models and strategies of communication and breaking bad news, because it does not only apply when we give our patients a bad diagnosis or distressing news. It can even apply at home. Communication is what makes us who we are, because we communicate. And it can just be just telling the housekeeper that this is the last month that me and you will work together, and you just gather all those strategies and align yourself and see how best you can approach what could have been a very distressing and agitative conversation to just being a calm one and explaining, so that you part ways in a harmonious way, regardless of the bad news being the situation. So it is actually time, as you've been invited, to just raise your hands, and then we can share your experiences and ask questions or any comments. Yes, Dr. Hassan.
Thank you, Sister Lepheane, for this opportunity and great presentation by Dr. Gillian and Dr. George. I'm sure the audience have learned and enjoyed. I just want to highlight one sentence, what I liked most, Dr. Gillian and George presentation. When Dr. George was mentioning those 5 topics to remember in spikes, I always practice in my clinic. I'm in Sinkaton Oncology Clinic in the palliative care facility. So when the patient and the family members are in the discussion, I'm this side of the table and they are on the other side of the table. I always keep in mind that maybe someday it can happen. I can be sitting on that chair on the couch on the other side of the table, and it makes my work so comfortable and easy when I believe that, and everything just goes step by step, just like that. So that was my note. Thank you very much for mentioning that again.
Wonderful, wonderful contribution, Dr. Hassan. Thank you. Anybody else that might want to share or ask, or just something that really resonated with you as the presentation went on, or any important statements that you have taken into your hearts, please? We are all free to contribute. We are all here learning, and we all have something to share.
Hi, Tebello. I like
Hello.
Hi, everybody, and thanks for the presentation. One thing that really struck me and often does is that when we communicate with people, it's not up to us to determine whether or not we're good communicators. And it's very easy for us to think, well, we communicated very well, and it was their problem that they didn't hear what we were trying to say. I really like that reminder. And then also just how much is not, how important it is to speak the language as well. And I don't know how many different languages you have in Lesotho, and what your experiences there are in communicating in different languages.
Thank you very much, Esther, for your contribution. In Lesotho, we have one main language that is spoken by almost 98% of the nation. But we have got another language in the southern region, mostly in Kuting. But most people speak just one language, which is the Sotho. But then the second language that is known would be English, but primarily we are just one nation, mostly with one language. So language is a very important factor.
Thanks.
Anybody that might want to share? We are all different professionals here with a different perspective of breaking bad news. Anybody?
There are some hands up.
Hello. Oh, right. Oh, okay. Dr. Annette.
Hi. I was just going to say hello, and also to say that one of the hardest breaking bad news that I had was not just the patient, the gentleman knew his diagnosis. It was when he then had a fit, unfortunately, and was told he couldn't drive. And he was a market trader, and his whole reason for being really was to every week to go to this market stall and set up his stall. And he was quite a loner otherwise. And every time we talked about, well, we could, you know, if you're going to get lonely, we could arrange for this, we could arrange for that. We'd missed it, you know, that wasn't the issue for him. It wasn't about us arranging to take him places or working out how he can do it. It was the fact that his independence and what made his life worth living was being able to go and get the vegetables and things himself and take it to the market and set it all up. And that's where he met the people. And I think it's just really good to remember that sometimes the hardest thing for somebody is not the diagnosis, it's how it impacts on some really major part on their life that we just don't always realise. Because I would think, okay, I can't drive, that's absolutely awful, but I'm sure I'll work another way around it and a friend will do this, or I'll find public transport to that or something. But for him, everything we suggested, it was his being. In fact, he had his little van, he drove his little van, he filled up with his vegetables, he took it to the market. So it's just really important to realise that for different people, the bad news will be a different thing, and we can't presume, not that we'd ever try and presume, but just kind of what it means to them. And it was a real learning point for me anyway.
I mean, I think that, sorry, I think that's absolutely true. And I will always remember a consultation where the gentleman was seriously ill. He was a butcher and he wanted to know when he could go back to work. And he was told, oh, you don't need to worry about that now. That's not an issue. Absolutely, it was an issue for him because it was his identity. And because also he was the breadwinner. He wanted to earn for his family and look after his family. And as an example of poor communication, it was just classic. So it's about what it means to the patient, not what we think it matters.
Thank you. Thank you very much, Dr. Gillian. Matebwampana, if you can introduce yourself slightly, where you come from. By the way, Dr. Annette is a palliative care consultant in Wales, friend of Starlight that we are looking forward to seeing her in Lesotho at some point. Thank you.
Thank you, Tebello. My name is Matebwampana. I am from National Health Training College. So we are training nurses and other health professionals.
Thank you.
I think there are so many things that you think you know, but that you really don't know. I wasn't aware that effective communication reduces isolation. So I'm very happy that I learned that is very important to me. Also, when I listened to the presentations, you find that indeed it is very difficult all the time to break the bad news, but you never really felt how difficult it is for the person that you are breaking the news to. Because sometimes, like it has been said by Gillian, that we think we know what people are going through. We think we understand what they go through, but we don't know what this means to this person particularly. So it is, I think I like the fact that we need to understand what it means to the patient, what it means to the family, because sometimes we think that the person, this person, this thing is not important. She cannot worry about the work, as Gillian had said. But to that individual person, yes, indeed, it matters. So I think it is very important. And as we are teaching our students, maybe it is a point to actually highlight and also avoiding to interrupt the patients. We tend to interrupt because we think we know what they are going through when we don't know. Thank you very much. Those are the take-home messages that I managed to get. Thank you so much.
Really appreciate your contribution, Mempana. Anybody else that might want to contribute from faculty side or from participant side? We are left with 3 minutes before we move on to the next session.
Tebello, may I just comment? In the chat, Amelia Mashea has put, the most horrific experience I ever heard was when the doctor was telling the patient that you are going to die. Yes, we are encouraged to tell the patients the truth, but I found that phrase very distressing. And I think that's absolutely right. We would all agree that that's very distressing. So I wondered if Tebello, you would care to comment on that.
Honestly, Dr. George, I can identify clearly with what Amelia has written, because certainly it has been my experience too. And this is one of the things that really inspired me to actually enter into this journey of palliative care, because I just wondered how many people should be receiving the news as I did, because at some point when I was called in that my mother has just been affected and involved in a car accident, by getting to the hospital, just while standing there trying to find out if indeed they've had somebody of those names amongst the casualties. Somebody, out of not even paying attention to look even straight into my face, just says, just go around the corner, you will find the body on the trolley. And that is how I learned that my mother was amongst those that were dead, that were over 8 people. And it was really disheartening. Being the only child of my parents, I had to get on with it straight on, arrange for the funeral without even having time to grieve, because I have to start hitting the road, trying to find where the insurance companies are to really get going with the preparation. And when everybody thought I was settled and I had accepted, it's been a couple of months down the line, that was when I was just really grieving and dying deep within me. So how the news is broken, just like Dr. Gillian said, that Maya Angelou has said those words. And one of the other words that she really says is that I can always forget what you said to me, but I will never forget how you made me feel. So definitely, Mema Shia, you have really struck the point. It can be distressing how the news is delivered, even in the midst of trying to be honest. We just need to be compassionate and sensitive and really be humane in our being. And that is why this call is about the transformation. It's not just to inspire or to motivate people. It is just at the core of it. We are here to really change the mindset, our practice, how we view things, change the perspective, and be able to compassionately give what we have and share our time, our skills, our ideas with the ones we touch, whether they are patients, our colleagues, or their families. So we are all here to try and do that. I think if there's any other one comment, we have just hit the minute to move on to the next session. Any burning issue? Yeah, Gillian?
Well, it isn't a burning issue. I just want to endorse what Joan has written in the chat about communicating with children. We tend to be focusing on adults. We'll always be thinking about adults, but and my experience is that many professionals are very wary of talking to children. They're very scared of putting their foot in it, in going in with, we sometimes say, with hobnail boots, and because they don't want to do that, they end up tiptoeing round and not being honest. Children are quick, I think, quick to notice dishonesty or prevarication. And certainly in my research with children whose parents were dying, what they wanted more than anything else was not to be treated dishonestly. They wanted to know the truth. They wanted to be respected. So yes, absolutely, Joan. Everything that you say is so right for children.
Thank you very much, Gillian, for acknowledging that. And certainly, indeed, I would like to even apologize because I'll try my best within the given time to do this case presentation. But one of the things that as I was trying to review it last night to see if I can cut down the slides to a reasonable amount, I really found it difficult because it's about the children, just like Major says, and Gillian has echoed, that is quite challenging and difficult to communicate with children because it has got all the dynamics of the family and the child and the sensitivity between the two. So we will just move on with this case study. And in this discussion, it is about trying to see how we can communicate with the parents when their child is unwell and probably has relapsed from a life-limiting condition, how to address some of the child's concern as individuals, and then whether to even check when the child does not even understand their diagnosis and prognosis, how do we really communicate? In this case scenario, we have got this 6-year-old girl. She has got this tumor in her right eye. And unfortunately, several months ago, the eye has been taken out in another hospital. And the family has been advised to actually now move on to the next stage of treatment, to go for chemo. But unfortunately, they can't afford to travel to the capital city for treatment because of limitations around finances and all that. And now we see the child come into emergency department with the evidence of tumor. It has progressed, and the right orbit has got now the swelling. She's got abdominal swelling as well, and severely undernourished. There is also limitation to open the mouth. There's also this foul smell as the child is breathing and having challenges with swallowing. So now the diagnosis is around retinoblastoma. So the mother and father of this baby, they are with her at the emergency department, and the father is a farmer, while the mother is just a housewife. Also, they have got 2 older daughters, 18 and 12, and the parents have sold most of their valuables and assets like land. They have spent all their money to try and get to the hospital. So they were previously told by the surgeon that after that surgery, when the eye was taken out, that the child was cured. They never understood it properly about the chemo issue. So the child studies first grade, that is class 1, but stopped going to school a year ago following the original diagnosis. She is aware that she has a mass in her eye, but it doesn't know much about the details of the illness. She's concerned about her parents because they are always crying most of the times, and they appear to be anxious, especially the mother. And when she sees her parents crying, she is really concerned. She feels better when she's playing with the other children, her friends. Palliative care perspective of this case: this is an advanced metastatic recurrent cancer with no chance of cure. This news needs to be provided to the family in a compassionate way. How will you tell them this news? Outline the steps you will think about when you see them, how you are going to share the news, review the way you will discuss the results with the parents and the extended family. We have just been informed about the model of our communication, the spikes for breaking bad news, as for setting up, perception, invitation, knowledge, and also recognizing the emotions of the people you are breaking the news to. Also try to paraphrase and summarize the main points of the conversation. And even after each and every aspect of discussion, try to summarize and paraphrase just to make sure you understood them clearly what they meant. So setup, this is very much important. What are the important things that you need to consider as you set up the scene for discussion? So just think about them, whether you needed to really get a room at the corner of the ward, try and minimize the distraction, possibly put even the poster at the door that the meeting is ongoing. Try to take maybe the keys or even the phone for the workplace. Leave it with your colleagues so that they don't disturb the conversation while you are in the middle of sensitive news. Perception: what words would you use to try and establish the understanding of the situation? Set up what are the important consideration. See them in a private room or a quiet place. Invite the counselor if we have one, or a psychologist, or even the colleague being the nurse. This is in a case whereby the news is being broken by the doctor. And then ensure the palliative care team is present, which is what we are trying to build in our Kingdom Lesotho, so that we can have the multidisciplinary approach to see that we are able to collaborate in terms of supporting the patient. What about the perception? What words would you use? What have the doctors told you? That could be an opening statement to establish their understanding. Make sure you remember their names by having had a prior time to check at their notes. And then you check again, what is your understanding of why the child is sick? And you still mention the name. Then it is about, we are still going through the spikes model here. Invitation, or you then check, what words would you use? And then how would you even check their knowledge base? What would you say to establish their understanding and knowledge about the situation? Then you can even check by saying, can I tell you more about what is happening? You are inviting them into the space or for trying to get more information. If they are not ready that day, or they feel overwhelmed to take on more information, they will let you know. Then we don't have to bombard them with this news when they are not really having the readiness to perceive and capture it. Then what about the knowledge? Then you just give them the warning shots. Unfortunately, I have bad news. In that way, you really let them reconfigure their mindset so that their emotions are on the level and tone of receiving this untoward and unpleasant news. Then you continue. The tumor in your daughter's eye has come back after the surgery. Then allow silence, like Dr. Gillian and Dr. George mentioned. Allow them to really express what they have heard. They might just show the sigh of a deep distress, or the body language, allow that moment to settle. Don't jump in quick to continue with the news. Then when you see that they are ready, again, they are eager, they are paying attention, their eyes are glued to your face to really try to establish further about this information, then you can even go on a lower tone. This is cancer, and it cannot be fixed with the medication. This is now a journey whereby you are letting them know they are entering into another space, because the condition will not be treated with the ordinary pathway of chemo and radiotherapy. Then you establish and acknowledge their emotions. How do you acknowledge them? Then the summary and the strategy. What are the next steps that would be suggested to support the patient and the family? So in this case, then, we have to make sure that we express that compassionate attitude. I wish the situation was different. That is being humane and being in their situation. Then there's this model as well, which is called the NESS model for empathetic responses by Smith, 2002. And for you name the emotion, I can see that you are feeling very angry, or I can see that you look upset. Then you for understanding. I expect most people would feel that way in your situation, and allow them to express, allow them to really say if they want to say more. And then respect. You have shown remarkable courage. Acknowledge that they are courageous in this unpredictable and really distressing journey of seeing their child being unwell. Empower them, make them feel that there's something good that they are doing in the midst of all this distressing news. Because otherwise they're already feeling like they are helpless, they are hopeless, and they feel even guilty, probably, that they have not taken the child to hospital when it was advised to go on to chemo journey. Then try and offer them support. That is all that we are there for. We will support you through this journey. Then give them the options that are available. There's a palliative care team, or we will have medication to manage the child's symptoms and ensure that the child is not distressed. Or there will be a social worker that will be visiting the home to try and establish the needs of the family and see how best we can support in every way possible. All those possibilities are there to show all the support. We have got community health workers in the village. We will communicate and refer you back in the community or your local clinic or hospital where they can really get in touch with you and support you. And that is what Starlight will be doing as well. We will be having this 24/7 line where the patients can call in and be answered and be supported. Then explore. Tell me more about how you are feeling. Find out more about their priorities. What are their major concerns? Dr. Gillian and Dr. Annette have just shown what could be the simplest thing that you think, don't worry about that now. Don't worry about going back to your butchery. It is that significant at that point in time for the patient. So we should not underestimate the significance and importance of patients' priorities and their families, and the child as well, if they are able to communicate. And then we check the overall understanding. Do you have any questions for me? Review the plan for the next steps. Document the discussion to ensure clear communication of what has been discussed. And that is why it is very, very significant that as they are communicating, we give them all our total listening capacity. That is generous listening, ensuring that we are compassionately with them in that moment as we are listening. After parents are made aware about the prognosis, they had difficulty in accepting that there's no more treatment available to cure their child. Then multiple counseling sessions with the team members needs to be established. Communicating with the child herself. You can use drawings and toys and ensure that you engage the child with whatever possible communication tool they are able to use. Because the May Jones children that are there in Sunflower in Bloemfontein, they tend to be drawing all the time and communicate how they feel through the pictures or even use of the toys or how they play around with those toys. So let me see the time. It might be my time is up, isn't it? I think so. Okay, yeah, my time is up. My time is up. But after several weeks, the parents were in acceptance stage after repeated counseling. Palliative care understands child's concern using art therapy and toys. That is where we involve the psychologists, the spiritual counselors, and the chaplains. The discussion questions are these three as we prepare to go into breakout rooms. My colleague, Professor Christina, will assign us into different groups where we will have for our facilitators being faculty members. Then these are the questions. If you can maybe copy them or just take a picture with your phone if you can, so that we can now be assigned to different groups, because these are the elements that our questions will be discussing as we have those 20 minutes in our individual small groups. So what have you learned about communication skills in palliative care? Share an example when communication with palliative care patient didn't really go well, and what did you learn? Share an example of what you hope to put into practice this week at your workplace. So thank you very much indeed. We can just be assigned to the groups now.
Tebello, I'm seeing about 9. I thought I saw Harriet on here. Yes, she's there. Okay, so Harriet, I'm gonna hopefully you can facilitate one of the group rooms. I'm going to break us out into group rooms and just give me a few minutes here, and I'll assign your professors to your various rooms. I'm going to begin now.
Christine, sorry.
Yes.
I'm doing something else at the moment, so don't put me in a group just yet.
Okay.
Okay.
While we are being assigned into the different groups, can we remember the feedback at the end of the session? The link is being shared in the chat, but I will also share it in the WhatsApp group, please. It always helps us to know how we are doing and to continue to improve.
And Professor Edwards, are you able to facilitate a group?
Hi, I'm not a professor.
Oh, sorry.
I'm just I'm a normal doctor, but I'll certainly help facilitate a group. That's fine.
Thank you. Okay. Tebello, go ahead.
Oh, thank you, everyone. It could have been nicer to really have some feel of how the discussions went on in the small rooms. But I think one or two people who have got maybe some things to share, we will still have for some minutes to wrap up and close. If anybody is willing to share anything, they are very much welcome. But indeed, in our group, there was a great acknowledgement and appreciation of our Spikes model. And we had a team of educators and the clinicians that are working at Sankatana as well. So they were really sharing their experiences of how they have been involved in breaking news from different perspectives of giving students their bad results and telling them they have to supplement or even repeat it the whole year. That was breaking news in a way that changes somebody's perspective of their future and life ahead. And again, Mayor Hashule from Sankatana also had a fantastic examples of how things have been going on as in terms of when they break bad news to the patients. But all in all, it's all about acknowledging to invite the patients into understanding what level of information they want, how deep do they want it, and whether they are ready. So anybody, Dr. George?
Oh, you're muted, George.
Yeah, thank you. Like you, we had a very interesting discussion about other situations. And our colleague, Makatieho Lese, who's a pharmacist at the hospital, introduced another very challenging conversation that she has on frequent occasions. Makatieho, are you able to speak?
Yes, George. Good evening, everyone.
Tell us about your experiences at the pharmacy.
At times it becomes very difficult for us to break the news to patients that maybe we've run out of stock or drugs have been delayed from our supply, and so it is not easy to tell patients to after a week or after certain days, because due to financial constraints, some people or patients may not be able to come. So it becomes very difficult to break the bad news to them.
Thank you. And you found today that there are some skills that you could draw on that might help you and your colleagues in the future?
Very much. I've learned a lot of how I can approach it.
Because we talked about how difficult it must be for Makatieho and her colleagues suddenly for a patient to become and their family very distressed that they can't have access to their drugs. They've got to leave the hospital. They have no money to get back. And you can imagine the intense distress that causes for everybody. So thank you for that. And just very briefly, we had another interesting example of Masakeko Ramasaha, who's a midwife. And of course, she is in a situation where something might have gone wrong with the delivery, or a patient might have lost a lot of blood, or there's a worry about the baby and suddenly a cesarean section is necessary. So I'm really grateful that in my group, there were these two really useful examples of difficult situations around communications that they have shared. So thank you for that, and thank you, Tebello.
Thank you very much, Ndati. Any burning issue before we wrap up? Honestly, I would like to also acknowledge our faculty members who week on week are always sacrificing their time to be with us so that we are all empowered to take the journey ahead. Our Lesotho needs us more, and it needs all of us with the different skills, of all of us being compassionately and intentionally going ahead and applying the skills that we learn here. Like I said earlier, it's all about a transformation. And every change will only take effect if there's a change of mindset for the better. Honestly, we are here and we exchange this time. The one that gave us this time, we honor it by just impacting the experiences, the knowledge, and all the journey of our careers and even our personal, in a way that we will try and change how we care for our patients, how we care for their families and support them. And we are grateful with all this wealth of experience from all our colleagues and our faculty team. So we thank you all our participants for making time. Despite all the challenges of connection, you have made so many attempts, some of you, to try and reconnect each time, and we appreciate. We are indeed privileged and believing that we are all one team in one journey, taking the care into another level. We are the multidisciplinary team, and I'm grateful to you, each one of us. So next week, we shall be having Dr. Amabel. He is from Uganda, and not Uganda, Rwanda, I'm sorry. And he will be sharing the knowledge around pain assessment and management in a limited access to essential medications, including morphine and other essential medications as listed by World Health Organization. And the session will be facilitated by our colleague, Esther Beatty from Canada. And we will be having case presenters as Dr. Ian Harps and Dr. Tony. So looking forward to seeing you, and we shall share the recording later, probably tomorrow, and we will have the feedback link as well in the group. We also acknowledge our friends and colleagues that joined us just to support the journey. Dr. Annette Edwards, I have seen also, let me see, maybe she's gone. Anyway, just to appreciate each one of us, and also say thank you, and God bless, and have a wonderful evening. And you, Christina, wonderful morning.
Thank you. And thank you to Annette for jumping in to just facilitate the group on your first time in here. Appreciate it.
Oh, we appreciate, honestly. Yeah.
It's been lovely to join you all.
Thank you.
Thank you, everybody.
Thank you.
Thank
you,
everyone.
Bye. Thank you so much.
Thank you.
Thank you, George.
Bye.
Bye.
Thank you.
Thank you. Bye.